Wonderful. Good afternoon, everyone. Welcome to Assembly Committee on Health and Human Services. I will begin the meeting, but Madam Secretary, please call the roll.
Assemblywoman Benitez Thompson.
Here.
Assemblywoman Black.
Here.
Assemblywoman Gorlow.
Here.
Assemblyman Hafen.
Here.
Assemblywoman Krasner.
Here.
Assemblyman Matthews. Assemblyman Orentlicker.
Here.
Assemblywoman Peters.
Here.
Assemblywoman Summers Armstrong.
Here.
Assemblywoman Thomas. Assemblywoman Titus.
Here.
Chair Nguyen.
Here. Having a quorum, we are ready to go. I would note that Assemblyman Matthews and Assemblywoman Thomas are absent excused. Today we did have three bills on our agenda, but we are not going to be hearing Assembly Bill 386. So I just wanted to let everyone know that. We will be starting off today's presentation with Assembly Bill 345. 345, hold on one second. 345, I will now open the hearing on Assembly Bill 345, which revises provisions relating to substance use disorders. We have our own Assemblyman Orentlicker from HHS here. Please begin when you are ready. And if I can remind our presenters to please clearly state your name for the record before speaking, just so our committee secretary can make sure she is capturing who says what when.
Thank you, Chair Nguyen. David Orentlicker from Assembly District 20 in Las Vegas and Henderson. And I'm grateful for the opportunity to just present Assembly Bill 345 today. I am joined by some experts, Joanne Chetta and Alex Kroll, who will talk about the research on these sites, and then also some other people from the community who know a lot about opioid abuse and how we can deal with it. So AB 345 is designed to reduce harm and save lives in Nevada. And I've had much help in development from Joanne Chetta and Megan Kamlasi here in LCB. And the seeds for this bill were planted 3 years ago when at UNLV, our health law program, we hosted a conference on the opioid epidemic in Nevada in the United States. And we invited Professor Chetta to come speak about the experience in other countries with addressing similar problems. And when she talked about overdose prevention sites, it blew me away. The data are just amazing and how effective they are in preventing overdose deaths and transmission of communicable diseases. So when I heard that presentation, I thought, we need this in Nevada. And so I'm glad that I have the opportunity to present that to you today. I also had great help from Lisa Lee, Carla Wagner, Leah Moser, Robert Harding, experts here in Nevada, and other members of a working group that when this was BDR 978, and also Jason Griffin helped out on this. So I want to start, this bill is designed to reduce harm from the problem of opioid use. And harm reduction is, here's one definition, a set of practical strategies aimed at reducing negative consequences associated with drug use. We can do harm reduction in other settings. It's not just drug use, but that's a common area where you have a behavior that causes that you can't control entirely. Sometimes you don't want to control it entirely. Sometimes you do. But at least if it's going to exist, you want to make sure you minimize the harm that's caused. So here are some common examples. And it's a balancing act because if you want to preserve trying to reduce the harm but not go too far, and it can be a difficult balancing act. But here's some examples. One thing, not driving if you plan on drinking alcohol, having a designated driver come with you. Consuming nicotine in the form of gum or patches instead of smoking cigarettes. So at least you're not doing the harm from the cigarette smoke to your lungs. Distributing, and here's something that's been very common in the United States, and including Nevada, distributing sterile injection devices to reduce the spread for people who inject drugs to prevent the spread of HIV or hepatitis. So these are all examples in the area of drug use, but here's another example in another setting, and that is seat belts and airbags in motor vehicles. We hope we don't have automobile accidents, but we can't eliminate them entirely. So at least if people are wearing seat belts and have airbags, we reduce the harm from motor vehicle accidents. The opioid problem, this has been a serious problem, and especially during the pandemic in the United States and in Nevada as well. So, for example, in 2019, almost 50,000 people in the United States died from opioid-involved overdoses. This past November, the National Drug Hotline placed Nevada on a red alert status because of the increase of death from overdoses, and we've seen this problem be exacerbated by COVID. Here's a chart that shows states from 2019 to 2020, the increase in opioid problems, and you can see Nevada, we're in dark red, which means we've seen more than a 50% increase. The American Medical Association a few months ago put out a statement urging governors and state legislatures, to take action and implement harm reduction strategies. So this bill, AB 345, has two components to save more lives. One is to authorize overdose prevention site pilot, and I'll talk more about what that means. And two, to make sure that doctors are prescribing naloxone prescriptions, giving naloxone prescriptions to patients who are at higher risk for overdose. And these two together will provide more harm reduction from opioid abuse in Nevada. So I'm going to turn now to my co-presenters, Joanne Chetta and Alex Kroll, to talk about what we know about overdose prevention sites. So Dr. Chetta, if you could join us now.
All right, let me get my screen up. Oops. Thank you very much for the invitation to be here. My name is Joanne Chetta. I'm a professor at Columbia University's School of Public Health, and I congratulate the Assembly for opening a discussion on this important bill. In the mid-1980s, HIV linked to drug injection was exploding in Western Europe. And the Swiss, among other authorities, decided that they needed to do something innovative to try to stop the harms that were coming from this enormous increase that they were seeing in drug-related HIV. And so you as legislators might be interested to know.
Sorry to interrupt. We cannot see the screen share. So can I get you to go ahead and stop that for a moment and then restart it?
Stop the share. Okay.
Go ahead and restart it.
Still not? It says you are screen sharing.
Yes, we are good now. Thank you very much. I appreciate it for the interruption.
No problem. I won't introduce myself again. I would just say again, in the mid-1980s, as this drug-related HIV problem exploded around the heads of people, the Swiss decided, in the shadow of their own parliament in Bern, to create a space where people could come and inject drugs, but with medical personnel around them, so that if there was, so first of all, to be sure that people had clean injection equipment, and also if there was overdose, for there to be medical people to help reduce the harms of it. Since then, these services have multiplied, as you see, all over Western Europe and to some degree in Central Europe, as well as 37 of them in Canada and 3 in Australia. In Canada, there was only one supervised consumption facility opened in 2003 until 2016, when Canada realized it had the same kind of dramatic increase in overdoses as we have experienced in the US. And then those sites again multiplied across the country. Because of this decades now of experience that we have with this service, and thanks to the enterprising work of a lot of researchers, I would say especially those at the University of British Columbia in Vancouver, we have a robust body of evidence to look at the outcomes associated with this intervention. Obviously, these services were created to reduce overdose, and most of them boast many, many thousands of overdose episodes without a single death or brain injury associated with overdose, again, because people have help right nearby. Needle sharing obviously goes down. That means HIV transmission as well. The better ones of these services, and I've visited many of them around the world, have good systems of referral to other kinds of health and social support, including in many cases, access to various forms of treatment of drug dependence. The service in Vancouver that's been so well studied actually has on the premises a drug treatment facility. Obviously, a less unsafe disposal of syringes. Most of these places have been able to demonstrate a decrease in open drug scenes and public disorder. There's no evidence that I know of in the literature, the peer-reviewed literature anyway, that there's been an increase in crime in the neighborhoods where these services exist, and no increase in initiation of drug use, which is often a fear expressed. I think this last point is one that's frequently overlooked, but that's very important to the cost effectiveness of these services, that we're looking at cases that come inside these services instead of being on the street, where if there is a difficulty or overdose or another kind of difficulty, ambulances, EMTs will have to come, people will be taken to hospitals. That all has declined dramatically in places like Vancouver, where I visited before the neighborhood in question before the service opened, and it was just constant back and forth of ambulances and lots of people going to hospitals who now don't need to. In spite of this evidence, when the Conservative government was elected in Canada in 2006, it decided to close down the facility in Vancouver. That was challenged by some people who use drugs, and the case went all the way to the Supreme Court, where the Supreme Court in a unanimous decision showed that it was very much convinced by the kind of evidence that I've just talked about, without any kind of negative evidence that it could see lives were being saved. And so Insight continued and was a model for the many services that now exist across Canada. I just wanted to show you from a visit that I made to Berlin that in Germany, the Germans have gone beyond the first model of a sort of stationary overdose prevention site to have mobile ones. On the right there, you see the inside of a supervised consumption bus. And again, the political viability of these facilities is that they have now a very long history, thousands and thousands of overdose episodes with no deaths on their premises. And in Germany, as would be the case in the Netherlands and a number of other places that we could look at, these services exist in part of a spectrum, a range of harm reduction services. You see that I've explained some of them here, both fixed and mobile drop-in centers, fixed and mobile consumption spaces. There's also first aid centers where people with soft tissue infections can get those treated, free HIV and hepatitis testing, even a place in that last symbol on the list there where people can bring pets. Now, these symbols are well known in Berlin. People know what they mean. They know what the roots are of the mobile services. So this is part of, as I say, a range of harm reduction approaches. And as fentanyl has become, you know that fentanyl is the culprit in much of the overdose mortality in North America. As fentanyl markets expand their reach, unfortunately, now to Europe as well, some of the services are starting to do things like testing of the drugs that come into their centers for the presence of fentanyl or fentanyl derivatives. And then, as is shown here in this material from the Harm Reduction Coalition here in New York, people can make a decision about whether they want to take their drug, whether they want to take it more slowly, whether they want to modify their behavior accordingly. And let me just say that it's obvious from the picture that's shown here that the European Union has never seen the level of overdose mortality that we are now suffering with in the US. And I think that that's for three main reasons, maybe among others that we could talk about as well. But first of all, because of this commitment to investing in a broad range of overdose prevention services and other harm reduction services that are supported by government money, not just by NGOs, as is often the case here. So they're very sustainable. They're considered to be part of primary care. Secondly, with nationalized or quasi-nationalized health systems, you would not see the same kind of out of control, unscientific marketing, aggressive and deceptive marketing of opioid medicines that caught us up here, and that was in many ways an engine for this dramatic increase that we see in the graph. And thirdly, and perhaps most importantly, in most of these countries, minor drug offenses, non-violent drug offenses are decriminalized, or at least depenalized, which is to say that people don't go to jail for them. So there's more of an opportunity to steer them to a range of health and social services. I just wanted to give you a few links to some of the sort of more summaries of the research that we have. So you can see with the more recent one by Armbrecht and others from ICER, you'll be able to see some of the more recent peer-reviewed literature. The second one here was done for the city of Philadelphia when it first started considering having a supervised injection or overdose prevention facility. And the third one is the evidence that actually went to the Canadian Supreme Court from the pilot years of the Insight facility in Vancouver. Thank you very much.
Assemblyman Ornlicker, do you have, oh, I see Mr. Krall's going ahead.
Alex Krall, can you hear me okay?
A little louder, please.
Okay, great. Can you see my screen as well? Is that working, the share screen?
Broadcast services, can we confirm that the public is able to see this presentation?
One moment, Chair Wynn. We are working on that. It appears the public is not able to see that. Mr. Krall, can you please stop your screen share and then try one more time for us?
Okay.
One second while we check with our broadcast. Mr. Krall, you are good to proceed. Thank you very much.
And if you could speak louder, that would be helpful, please.
I will do that, yes. My name is Alex Krall. I'm a distinguished fellow at RTI International, and I'm an epidemiologist, and I've been studying drug use here in the United States since 1993. And one of the things, just to bring this to the U.S. Context, here in the United States.
I'm sorry, Mr. Krall.
Yes.
I think we're having some sound issues. I don't know if anyone else is having those issues based on the nodding of heads in the gallery view. Broadcast services, is there anything we can do to make sure his sound is a little bit louder? It seems to be really quiet.
Mr. Krall, one thing that you might try is to turn off your camera, just to lower the broadband. That might help us here with the issue. Can you speak now, Mr. Krall? See if we can hear any better.
Yes, can you hear me better now?
It's still fairly quiet. If you could sit closer and please remember to project as best you can.
We'll do that. Okay. So in the United States, at this point, we are having about 71,000 deaths in overdose per year. HIV, we're seeing 2,400 new infections a year. Hepatitis C, 38,000 new infections a year. Infective endocarditis, a heart disease, is something also on the up, with 20,000 cases a couple of years ago. And then soft tissue infections were also about 500,000 a year. So the health complications associated with injection drug use in the United States are quite broad. So what we've done in the United States is there are no legally sanctioned overdose prevention programs in the United States at this point. However, there is one unsanctioned site somewhere in the United States that we've evaluated, and that's been open for 6 years now. It essentially entails, much like what you saw in the previous presentation, 2 separate rooms, one for injection and one for post-injection. They have 6 stainless steel tables with mirrors and a table for assisted injection. And there's a staff person there in the room at all times who can help to save somebody or counsel them as need be. We published a paper in the New England Journal of Medicine last July that basically looked at all of the overdoses that happened in that site. And so during the 6 years it's in operation, there were over 10,000 injections at this site. There were 33 people who overdosed, and none of them died. They were all saved by the people who worked at the site. And also of importance is that there was never any ambulance called or required. And so this was a pretty big issue as well because of the resources related to having ambulances come out to these overdoses. We also did a study looking at crime in the neighborhood. What these graphs are, I know there are a few dots going on here, but essentially what you have on the left here is you have 10 years of data, 5 years before the site opened, and then you see the vertical line there, and then you have 5 years of data after the site opened. The green is the neighborhood within 500 meters of the site, and the blue, and then also on the right, the red, those are sort of control neighborhoods in the same city that are very similar neighborhoods, but that don't have a safe consumption site. And what you see is that crime, as per police reports, went down after the implementation of this site in the 500 meters around the site. But in the control neighborhoods, both in the blue there, you see things actually going pretty much stable. They went down similarly in one of the other control neighborhoods as well, but certainly it shows that there's good news in terms of crime around the site. I also want to add one more thing is we did a study that we published in the peer-reviewed journal 2 years ago that showed that if you implement the same type of site that they have in Vancouver in a city in the United States, it would save the city $3.5 million a year, basically because you have savings in overdoses, you have savings in ambulances not coming, you have less HIV, hepatitis C, abscesses, those kinds of things that I talked about earlier. This is why the American Medical Association in June 2017 voted to approve overdose prevention programs. And so this is something that's completely sanctioned by the American Medical Association and many state medical associations as well. Lastly, I just wanted to say, in the United States, this is not the only state bill that's currently up. All you see on the left side, you see there are very, very similar bills right now being argued and being deliberated in Arizona, in California, New Mexico, a lot of the states that are very similar around to Nevada as well. There are also many cities that have had mayors that declared that they want to implement these overdose prevention sites, and some of them on the East Coast, some of them on the West Coast as well. So that's the end of my presentation specific to what's going on around overdose prevention sites in the United States. Thank you.
Okay, thank you, David Orentlicker. May I continue, Chair Wynn?
Go ahead.
So thank you, Drs. Chetta and Kroll, for that very helpful information. So now I'm going to fix my presentation here. Okay, here we go. So As we heard, the American Medical Association has endorsed the concept of overdose prevention sites. The American Public Health Association.
Assemblyman Ortlicker, I absolutely apologize. We are not seeing your screen share.
Okay,
Can we please start it over again?
sure.
I apologize for the technical difficulties on our end today.
Thank you, committee, for being flexible.
Is it working now?
Assemblyman Ortlicker, we can see it now. Please proceed.
Excellent. Okay, so these, they indicate they've been endorsed by the American Medical Association, the American Public Health Association. So now I'll go through what the bill does. So in an overview, it has enabling language. It would not create an overdose prevention program by passage of the bill. It would enable a pilot program. So Washoe and Clark County would each have authority to open one pilot program in each county. And if that goes well, then other counties would have the option to. So this is an option for counties. Nothing's required, but it allows them to do it. It could be done either a brick or mortar fixed site, or as we saw in the Berlin example, we could have a mobile site. It would be operated by a health authority, an academic institution, say UNLV or UNR School of Medicine, nonprofit organization, or a combination of those, any of those three. How it would work. So as we saw, these are controlled environments with on-site trained personnel, and then you can connect the users you can provide education and connect them with referrals for treatment. And there would be oversight by state or local health authority to make sure that these are carefully regulated. And then in terms of the specific provisions, so there are a number of safeguards for the community. Before opening a pilot site, the authority or the entity that would want to do it would have to consult with law enforcement, health authorities, and the public. They would have to make sure that there's safe and proper disposal of used injection equipment. So we don't, one of the virtues we've seen, instead of needles and syringes being left out in parks and sidewalks and streets, they're disposed of properly in these facilities. And there would be oversight by local health authorities, county commissioners, and the State Board of Health would all have oversight authority. Some of the safeguards for the participants, these would be staffed by trained personnel. There would be just distribution of sterile needles and syringes, so they aren't transmitting communicable diseases. They'll be monitoring the participants, as we saw the example in the unsanctioned site where there's the treatment room and the post-treatment room. Administration of on-site first aid if necessary. If somebody does have an overdose, you can see they're fortunately not common. You can address that right away. And then consultation and referral for treatment for mental health conditions or substance use disorders. And then sections 9 and 10 have confidentiality provisions for the participants and also protection from any legal consequences, both for the participants and the staff at the program. So the timeline, as I say, this would enable the pilot sites, one each in Washoe and Clark counties. The pilots would have to operate as pilots for 4 years. After 2 years, if preliminary review indicates that things are going well as we expect based on the data from other countries and the unsanctioned site in the United States, then if after 2 years, it would be possible for the Board of Health to authorize pilot programs in other counties. And they would review the number of participants and what happened, were there overdoses and referrals and other things to gauge how they're operating. And then finally, after 4 years for any pilot site, there would be a formal review to decide whether it could transition to a permanent site. And then also whether, if it all went well in Washoe or Clark after 1 year, would they now be authorized to expand beyond the one site? Okay, that's the first part of the bill and the main part of the bill. There's also a second part of the bill in section 12 dealing another harm reduction policy, Naloxone Co-Prescribing. So the idea here is for people who are being prescribed opioids and who are at risk for overdoses, provide a prescription for naloxone along with the opioid prescription, so the patient will have on hand naloxone in case of an overdose. So 10 states have legislation or regulations on this. 8 states require that the prescription be provided. 2 states require that the prescription be offered. And what we see in those states, it does lead to increases in pharmacy dispensing of naloxone. What we don't know yet, we don't have enough data yet to know how this method of expanding access to naloxone compares with programs like we have in Nevada for non-pharmacy community distribution of naloxone. The provisions we have in AB 345 are modeled after Rhode Island regulations. They seem good ones to start with, although we'll talk about that some. So what we brought in from the Rhode Island regulations. And so if a physician is prescribing for patients at higher risk for opioid overdose, then they would provide a naloxone prescription. And the categories of patients who would be considered higher risk are if they're taking more than 50 morphine milligram equivalents per day, if they get to that high a dose, if they're taking an opioid and a benzodiazepine, that increases the risk, or if they have a history of opioid overdose or opioid use disorder. And one thing important, there's a conceptual, in our conceptual amendment, we took out previous sections 12.3 and 12.4, and there's a new 12.3 to clean up some problems that we had with the original language. So if you're looking at the people who would get this prescription, it's important to be looking at the conceptual amendment that's posted on Nellis. But it seemed like Rhode Island had a good model, but this one, is not, the data aren't as clear as with the overdose prevention site. So we welcome suggestions on refining the criteria. Maybe we're leaving some people out that should be in, maybe some people in who don't need to be in. We certainly welcome suggestions there. So I want to thank Natalie Johns and Aurelia Alarcon from my office for their excellent help in preparing. And if you'd like to co-sponsor this bill, I will be happy to add you on by an amendment. So thank you for allowing me to present, and I look forward to your questions.
Thank you, Assemblyman Ornlicker. I do believe we have quite a few questions, as I imagine we would, having such a big policy conversation about your bill. First up, I have Assemblywoman Titus.
Thank you, Madam Chair. And indeed, thank you, Assemblyman Ornlicker, for bringing up this discussion in this bill. I think it is a good policy discussion to have. I'm glad that you mentioned Section 12. That was one of the first things that I was going to, especially Section 12, number 3, where you describe not being able to prescribe the Narcan or reversible drug or opiates if you're given benzodiazepine. And I know you're not a practitioner, but as a practitioner, I would say it would be very important that the practitioners themselves make that decision. So I'm anxious to see what that looks like in your amendment, and I haven't had a chance to review that. So I'll follow up with any questions I have with that once I see that amendment. The next question I have is first a statement. The CDC released a graph recently on the overdoses. And we know that the opioid epidemic came in 3 waves, right? Then in 99, the prescription opioids. And then in 2010, the heroin overdoses. And then that 3rd wave with the fentanyl overdoses. So we in the state over the last several sessions, since I've been in session, this is my 4th one, we have successfully actually tried to curb that. And through that, we were an early state to adopt the Narcan prescriptions and allow that to be dispensed with the packaging, family members, those kind of things. We've really done that. We've held providers such as myself who do prescribe these accountable for how we do this. And we've also entertained needle exchange programs and all of that. So what I'm asking with this particular bill, since number one, I don't know if I need to know if any other states have this legislation. I heard a number of states are going to pass. Really curious about the number of states who actually passed this legislation. That would be my first question. So do we have that?
I'm happy to answer that. This is Alex Krell again. There are no current states that have passed that. There's a bill that's passed through both health committees and public safety committees in other states, but there's none that's passed so far.
And so the standard of care, I know that the first one started in 1986 in Switzerland. So this isn't a new idea. The first program actually started in Switzerland. And that was when I graduated from medical school in 81. So we were dealing with the HIV epidemic. And so we were dealing with some of the true issues about needle sharing. Since that time, however, we've progressed even in thinking about sharing, not being able to share needles. So I'm curious about the statistics on the actual drugs. Who supplies the drugs? What drugs are they allowed to use? Do they bring in their own? Or is this a volunteer program? And so who controls the dose of heroin? Do they tell the folks there that I'm gonna take an ounce of this? Who controls the actual process, and where do the drugs come from?
So Alex, I don't know, did you want to talk about the site you studied?
Sure, I'm happy to. Essentially, yes, people have to, there's no drugs provided at the sites. And so people have to bring in their own drugs and use their own drugs. And typically what happens is they will let the attendant know what type of drugs they're using. And that's essentially it. They are then free to use as much or as little of those drugs as they want to use. Obviously, if they use too much and were to overdose, then they're there to help save them at that point. But there's no drugs given out at the site, and basically pre-obtained. You're bringing them in yourself.
And so, is there? If I might continue, Madam Chair. Sorry. Thank you. So
Go forward.
Thank you. So when you bring in your own drugs, which is heroin, perhaps, and we know that that's still federally illegal, and it's illegal in the state. I'm curious about the federal government enrollment in this. Although conceptually, it's nice to be in a safe area, and I have done my homework on this. I do know that there's no, increased crime around there, and that you can prevent these overdoses. Do you see folks coming in just to push that envelope so they can get a new supply of their heroin, not know how strong it is, go in a safe site to inject that, get their high, and know where they're safe for that overdose? So is this more enabling than preventive?
Actually, the number of overdoses at these sites is actually lower than the rate of overdose in the communities. So that indicates to us that people aren't doing, or they're not more risky in these environments than they are out in the community.
And in the areas that you say, if I might, that have these locations, there's been a decrease in the number of deaths because of Narcan's available. You testified to that. But is a Narcan already available in these states, in these areas, or unlike Nevada where we already have Narcan available, is that the unique situation there?
The difference here between this and other things.
Mr. Kroll, can I go ahead and have you state your name for the record before you speak so we have a clear record?
Yes. This is Alex Krell, Distinguished Fellow at RTI International. And so the difference here is that when you're using drugs, if you are using them while you're alone, you could have all the naloxone you want, but you can't use it on yourself because you're overdosed. And so the point of these sites is to make sure that there's somebody there who is a professional who knows how to use that and has naloxone or oxygen, frankly, there available for them. That's the main intervention, really, is to make sure there's somebody there in the case that they do overdose.
Okay, and thank you for all of that. I just again I'm just curious in bringing it all back to the state of Nevada, because that's where we're looking at this. Assemblyman Orntlicker, have you done this recent pandemic, the studies that we've seen, and the decreased rates? And we've actually had lower rates of overdose in these three major things of overdose that we've seen. Some of them are actually going down, except for this pandemic, which is the outlier. And we are seeing overdoses in this last year an increase 5%, 6%, and it's a significant tragedy. Do you know how many of those, or the state of Nevada now I'm talking about, have been heroin overdose or other injectable drug overdoses?
David Orient, Liquor Assembly District 20 for the record. I don't have that. We do have a couple other Nevada experts who I think are on Zoom, Lisa Lee and Robert Harding, who may know. But let's bear in mind that it's what we always know is we get recurring waves. This is not an outlier that we have wave after wave. They seem to be inevitable. And I think the extent of data we have is quite impressive, and there's no reason to think that Nevada would be any different than what we've seen in all these other locations that have benefited tremendously from these sites.
And my final question is, would these be restricted to Nevada residents? Would you have to show an ID, health insurance card, some sort of healthcare information in case there is an overdose where you then have to reverse them? They do have to be hospitalized. How much information gathering will be mandated or required?
David Orient, Liquor for the record. May I respond, Chair?
Of course.
I don't know we haven't thought about that. I don't know in what way you would be. I'd certainly be happy to talk to you about it to see if that should be part of the legislation. I'd be interested in hearing whether the unsanctioned site, that's an issue for that.
Right. Yeah. My concern, of course, is, the overdose. If you need to seek health care, medical care, do they have to sign some sort of waiver at the door? How do we as healthcare providers take care of them if this happens? Having worked thousands of hours in an emergency room and dealt with overdoses, I'm just curious as how this process will work and how it will affect those folks given the care that these folks potentially may need. So again, thank you for all that string of questions. I have probably 1,000 more, but I'm gonna stop there, and I can reach out to the Assemblyman Orient Liquor offline. And thank you very much for the conversation and the questions.
Thank you. I see Miss Lisa Lee on the line. I don't know if she has any Nevada specific data that she wants to respond. But if you do, feel free to unmute and remember to state your name for the record.
Thank you, Madam Chair. Lisa Lee for the record. Data is always so slow to catch up to us. So I think the latest current available data on the opioid dashboard is from 2019. Data in Nevada show, pre-pandemic, about 400 people have a fatal opioid overdose each year. And there's a good share of those overdoses that are due to polysubstance of use of opioids and a benzodiazepine. So I think that's important to note with the co-prescribing of naloxone in Section 12. Things are looking, I asked the medical examiner here in Washoe County for the quarterly report. So I try to stay on top of that because I work, doing outreach with people who use drugs. And so I want to make sure that if there's a bad batch, I can warn people. And I now have fentanyl test strips that I'll be taking out and doing some outreach there and data collection up here in the north. In addition, I wanted to say that there is data collection planned. We're going through the IRB process currently with Dr. Wagner that will be doing some studies, collecting data with people who use drugs to talk about what's going on the ground, as well as acceptability of the OPSs going forward. I hope that answers some of those questions, Dr. Titus.
And if there is additional information, I would encourage you to provide that to Assemblyman Orient Liquor, and he can get it to committee staff to distribute it to everyone. We do have quite a few questions, so I'm going to go next to Assemblyman Hafen.
Thank you, Madam Chair, and thank you, Assemblyman Ornlicker, for the presentation today. I also have a number of questions, but I'm going to touch on two different sections of the bill, and then maybe come back after everybody else has had a chance. In Section 9, it discusses the confidential nature of the information that's being collected, and I know you're the expert on this, and so that's why I'm going to ask is do you think that language will stand up to a FOIA request, and that this information will not be released to individuals that do request it?
David Ornlicker, Assembly District 20 for the record. I think, I'm pretty sure it would, but I'll check to make sure. It certainly.
It looks like Ms. Lee has her hand up and might be able to answer that question. Go ahead, Ms. Lee.
Lisa Lee for the record. I would actually like to call on Robert Harding, who's present today. I believe Robert can answer that question more thoroughly.
Hi, committee, and thank you, Chair. I can address that. I just want to bring up that the language pulled for Section 9 is actually pulled from previous legislation here in Nevada that authorized the syringe access programs back in 2013. So we haven't had any challenges with those records since then. So I don't foresee any problems moving into the future.
Thank you, Mr. Harding. Mr. Hafen, do you have any follow-up questions? I think you had a couple.
One other question, and first of all, thank you, Mr. Harding. And my concern here is that, this is still, the actions are still considered criminal, and so I don't want this information to be released. So I appreciate the answer there. The other question that I had was in regards to Section 7, subsection 1 references that these will be operated by health authority, higher ed, or nonprofit, or any combination thereof. It didn't seem to be specific to Nevada higher ed or Nevada health authorities. And so part one of the question is that limited to the Nevada NCHI program, Southern Nevada Health District, or not? And if so, have they been able to provide you any feedback? And maybe they're on the line to testify later, but I just thought I'd get that on the record. Thank you.
David Ornlicker, Assembly District 20 for the record. Our assumption was they would be. I have had conversations with people at UNLV School of Medicine, and the person I spoke with said they would be very interested in participating in a project like this. And Lisa and Robert might be able to speak to University UNR. But our intent was that this would apply to Nevada entities that would operate it.
I believe Ms. Lee has an answer as well. Go ahead.
Lisa Lee for the record. Thank you for your question. We currently have still a large stakeholder group that includes people from the Southern Nevada Health District, as well as the Washoe County Health District and the Washoe County Manager's Office, as well as associate professors from the University of Nevada, Reno. So we are in constant conversations around these issues. It all depends on what happens with AB 345 going forward, but they are voices at the table in this larger stakeholder group. Thank you.
Thank you. Next, I have a question from Vice Chair Peters.
Thank you, Chair. So in this committee, we have talked quite a bit about the stigmas that we hold as a society around behavioral and mental health and the impact that that has on access to treatment, the type of treatment you can receive in some places, and feeling like the kind of the burden of carrying those issues in your life. And I'm wondering if you would talk a little bit about how this plan works to kind of break down those stigmas and destigmatize the mental and behavioral health related to addiction and other issues.
And Assemblyman Ornlicker, I see that one of your other people on the line to answer questions has his hand raised. Would you like me to go to Commissioner Segerblum? Go ahead, sir.
I apologize. I was actually referring to the previous question, so I apologize, Assemblywoman Peters. But I just want to say Clark County is very eager to go forward with this program. I've set up both the Board of Health and the County Commission, and I have places in my district that we're ready to go. So this is all we need, a little help. And I even though I'm testifying in support of the bill, I love the bill. I would urge you to.
We will give you the opportunity to testify in support, Commissioner Segerblum, when we start taking that testimony. I appreciate your eagerness, but Assemblyman Ornlicker, do you have? Oh, it looks like we have someone else that can answer Vice Chair Peters' question.
Joanne Chett at Columbia University. I just wanted to say that in many of these places, if you talk to, and there's lots of qualitative literature on this, if you talk to people who use drugs and use these facilities, they often say that it's the only place where they've been able to get non-judgmental care. And for many of these facilities, it's also the only way to sort of integrate them into any other kind of health or social service system. This is often the door that they will go through, people will go through when they don't want to go elsewhere because they fear stigma and judgment and discrimination. So again, I think the best of these facilities have really served to be a place where people can feel that they do what they need to do without being stigmatized and judged.
Do you have any? Oh, go ahead, Ms. Lee.
Lisa Lee for the record. Really exciting question, Assemblywoman Peters. As a woman in long-term recovery from opioid use disorder, while I haven't had the privilege of utilizing one of these overdose prevention sites, I can safely say that I probably wouldn't have lived with hepatitis C for 21 years. I can safely say that many of my friends would still be alive at this point. Stigma is a real thing that unfortunately ends in people not getting care that they need. I can tell you that, I have not gone to medical care and lanced my own abscesses while experiencing homelessness and being an injection drug user because of stigma, and was constantly endangering my life. Not to mention the people around us with necrotizing fasciitis and whatnot. That is a direct result of prohibitive policies and keep people who use drugs in the shadows without care. And so I think spaces like this are deeply meaningful. I know the opioid crisis has really been in the American sort of mass purview for quite a limited time, but I've been having an opioid crisis for decades. And I think of places like this, and I just know that a lot of people would still be here. A lot of people probably would not live with stigmatizing bloodborne infections. There would be limitations of soft tissue infections that go untreated and end up turning septic or into endocarditis. And so stigma is a real thing that kills people. And I'm glad you brought that up. And I'll stop talking. I'm very passionate about the stigma thing. Thank you.
I also see Mr. Harding. If you can go ahead and state your name prior to speaking.
Thank you, Robert Harding, for the record. Just to follow up on that and reinforce that, there are two forms of stigma. There's external stigma, which is the form of stigmas that are placed on a person. There's also internal stigma, which is when we take those stigmas and we start to feel them deeply within our soul and think about them as a person. And having harm reduction services that support somebody and support people who use drugs and provide that space and that environment really helps to break down and change that internal stigma, which can be just as deadly as the external.
Thank you, Mr. Harding. I have a couple of questions. And if you do have questions, please send me a message so I can get you in the list next. because we do need to get to our testimony and support opposition and neutral this bill, and we do have one more bill. So I have a couple of questions. I'm very excited that you have so much data to be able to analyze. Unfortunately, it is outside of the United States and a lot of these other countries that have different healthcare systems, have different public healthcare systems, have had, prolonged education campaigns to destigmatize this, as well. How do you see being able to take some of that data, and how do you see it playing into the success we might have in our healthcare model?
That's for me, Joanne Chett at Columbia University. Yeah, it's a very good question. And of course, the history is different. The nationalized or quasi-nationalized health systems make an enormous difference. The criminal law is different. I do think, however, that the actual service, the actual interventions that go with these services, or that could be linked to an overdose prevention site, have a certain universality from which we can extrapolate from the decades of experience that's already out there. Just because overdose is not different from, the overdoses that are suffered in Europe in the end at the moment of the episode are not different from the ones here. I don't know, maybe Alex has another perspective on this, but I think that the other data that's very useful is the cost data, and there have been some really good costing studies. And those, I think, are, it's rare to get good costing of any kind of intervention that deals with marginalized populations. And there, I think the data could be very useful for policymakers here.
The other question I have is, I just started to briefly kind of Google some of the other countries and a majority of them that have instituted or have these types of programs available have also decriminalized the drug possession. So how does that work here? I mean, this is still a felony charge here in the state of Nevada. So how does that work within this legislation? I don't want a situation where we have these facilities set up and there's just police officers waiting outside to arrest people going in or out of these facilities.
Joanne Chett at Columbia University. Assemblyman Orentlicker could answer that too, but the Canadian controlled substance law is very similar to ours. The sites there operate on an exception to the Controlled Substance Act that enables people to not be prosecuted for what goes on in the facilities. And it's a matter of community liaison work to be sure that the police are not standing outside to arrest people as soon as they come out. But that's not happening in most of these places, as you say, where possession is decriminalized. But basically, there has to be an exception to the to whatever drug control acts there are. Even in Western Europe, where there's been a longer history of decriminalization, the drugs are still illegal in most of these places. Not in Portugal and not in a few other places, but the law allows for an exception to the drug control criminal framework.
If I may ask, if I may add, this is Alex Krell for the record again. Yeah, the only country out of all these countries that decriminalize drugs is Portugal. None of the other ones have actually decriminalized drugs. Norway is just about to, but that doesn't span the data we have from the last few years in Norway. So it's actually not the same. And it's much like syringe exchange programs, access programs. You need public safety and public health to work hand in hand for these programs to work. We've been doing that successfully in many states in the United States, for decades now around syringe access. And I don't see a reason why you couldn't also do that with respect to this particular intervention.
Sorry, I just had some concerns, in addition to the question that was kind of asked by Assemblyman Hazen about, I would hate to have this as an option for, people to go and do FOIA requests, get the names and addresses of people that are in here and use that to further criminalize, people that are trying to get help. So I would love it if you could include that. You know, I don't remember seeing that in the language of the bill, and maybe I just missed it, but that's something that I think should probably be considered as well as part of the, you know, legislation. I'm looking around here. I don't see any other questions. Oh, I see another one from Assemblyman Hathan. Keep it quick.
I will keep this very brief. I apologize. Assemblyman Ornlicker, in reviewing the documentation, in the actual bill language, I do not see any age limitation on this program, so it doesn't preclude minors. The legislative digest implies that there is an age restriction where the person has to be at least 18 years or older. And so I didn't know what your intent was because I was not able to find that in the actual bill language, but it is in the legislative digest.
David Ornlicker, Assembly District 20. That's something I'd have to think about, but I invite any of our other presenters if they have thoughts about whether it makes sense to draw age distinctions or not.
I think I'm going to go to Mr. Harding. If you go ahead and mute yourself. I'm going to try to stick it to one person to answer the question. Otherwise, we'll need to move on. But go ahead.
Thank you. Robert Harding for the record. I would like to definitely address that question. I would encourage the committee to be cautious of requiring IDs or documentation, as that is something that someone living on the streets and living without shelter often end up without. And this program would be most beneficial to those individuals as they don't have clean, sterile spaces to utilize their supply of drugs. So requiring that we have some sort of ID documentation when they come in definitely creates a big barrier there. I also want to reinforce that again, the language that I brought in Section 9 from the prior syringe services program kind of went into address the anonymity of the program. One, to protect the clients from any kind of FOIA requests, and two, to keep that barrier low.
And Ms. Lee, did you have a response or an answer to like the juvenile question?
Yes, thank you, Lisa Lee for the record. I believe when we put together the original draft language, and I was just reviewing the bill as well to see, because I do see it in the legislative digest, but our intention was 18 and up in the language to answer your question. Thank you.
Thank you. And I just have one follow-up. I know I'm trying to move on, but in some of these other countries that have like programs like this, do they have age limits or do they target adults? Go ahead.
Joanne Chetta, Columbia University. In some of them, the facility staff are trained to refer people under age 18 to other kinds of services. But in some of them, there is no age, there's no proof of age required and no identity documents required that, for instance, in the ones in Denmark, which have been widely visited and where people who use drugs were part of the design from the beginning. I think that they serve everyone. They don't try to distinguish.
Thank you. I appreciate your presentation. I know that we have lots of questions and lots of comments. And like Assemblywoman Titus, and I tend to agree, we could probably be here all day discussing this. So I would encourage everyone to reach out to Assemblyman Ornlicker, and I'm sure he would be happy and willing to provide some of the contact information from some of the presenters that were here today. And with that, I'm going to start testimony in support, opposition, neutral of Assembly Bill. Oh, what's your number again? 345. I'll remind our participants to please spell and state your name for the record, and please limit your testimony to 2 minutes. Staff will be timing each member to ensure everyone is given a fair opportunity to speak. And with that, I will begin testimony in support of AB 345. I know that we have one person on the Zoom to testify in support of that bill. So go ahead, Mr. Segerblom, when you are ready.
Thank you very much, Madam Chair and members of the committee. I'm Tick Segerblom, Ticksegerblom, County Commissioner and a member of the Clark County Board of Health. Although I'm not appearing on behalf of those institutions, I can say that this bill is really fantastic. It's greatly needed. As you know, the war on drugs is over. We basically lost. Oregon just decriminalized all drugs, and I think that's the way the nation's headed. So now we have to deal with the issue of how we deal with people that actually use them, both as far as making sure that they don't kill themselves, and then how we can provide services so hopefully they can get off of them. My district includes the Flamingo Wash, which goes right next to UNLV. Huge numbers of drug addicts, drug users in that wash. They come out of the wash into the neighborhoods. There's syringes everywhere. We've started a syringe exchange program. So we started that, but the next step is going to be this, where they can actually come to a secure facility. And with respect to the fact that it's illegal, I'll remind you that marijuana is a seed is a felony under federal law. And yet I'm sure probably today or within the next couple of weeks, you're going to be dealing with not only marijuana laws, but having places where you can go smoke marijuana. So if you can go smoke it under your laws, I don't see why you couldn't also go to a place, bring your own fentanyl, wherever you have, and use that in some kind of a site. It just, the time is now. The one comment I have, I don't want to be an opponent of the bill, but I think one site for Las Vegas is really way too small. I would just say they ought to have pilot programs, but don't limit the number.
I will go ahead and have you encourage you to continue to work with the bill sponsor about any concerns you have about the current language of the bill. And with that, broadcast services, if we could go ahead and begin testimony in support of the bill.
Thank you very much.
To testify in support of Assembly Bill 345, please press *9 now to take your place in the queue. With the caller with the last 3 digits, 080, please slowly state and spell your name for the record. You have 2 minutes. You may begin.
Hi, Jim Hoffman, Hoffman, representing Nevada Attorneys for Criminal Justice. NACJ supports AB 345. And just quickly, I believe it was Chair Nguyen had a question about FOIA requests and criminalization. As I read the bill, Section 10 states that a person cannot be prosecuted, arrested, charged, etc., for involvement in this either working at the place or for consuming or possessing drugs in connection with it. So there is a basic level of protection there. For the bill as a whole, studies have shown that safe injection sites reduce the amount of outdoor drug use, prevent overdoses and transmission of disease, and provide wraparound access to addiction counseling. Nevada has spent the past 40 years trying mass incarceration as a response to drug use. That strategy has failed to stop drug use or the harms that it poses to society. Safe injection sites would be a new tool to address these harms in a beneficial way. For that reason, NACJ supports the bill. Thank you.
Thank you for clarifying that and for your testimony. If we can go to the next caller in support.
Caller with the last 3 digits, 039, please slowly state and spell your name for the record. You have 2 minutes and may begin.
Hello, my name is Erica Minneberry. That's ErikaMinneberry, and I am privileged enough to have been in recovery for the last 15 years. But 15 years ago, I did almost die from an infection that was left untreated. I do consider myself lucky because a lot of my friends did not make it to that point. They were never given the opportunity to recover, and they had very brilliant brains. If they were able to recover, they would have been able to do amazing things for this community. And I believe by passing this bill, lives will be saved and the community will be enriched. Thank you.
Thank you. If we can go to our next caller in support.
Caller with the last 3 digits, 632. Please slowly state and spell your name for the record. You have 2 minutes and may begin.
Hi, my name is Danielle Barneau, Barrineau. I just wanted to talk a little bit about my past. At the beginning of my drug use, I was kidnapped and sold for sex. And if that girl would have known about a place like an overdose prevention site, how amazing would that have been? I can't tell you how many times I tried to escape and my kidnapper would find me and beat me and torture me. I really didn't have a way out. I didn't know what to do. And if there was a place where I could go use safely, and also with all the resources that are available for human sex trafficking victims, how soon could I have been saved? How much less trauma would I have had to suffer if not for a place that would have been like that? So on top of all the facts that have been presented, I wanted to say that I think for girls that are out there that are suffering, that can't speak, that don't know where to go, and could not tell the truth to their pimp, to their sex trafficker, that they're just going to go and use and get some syringes, I think this is a great option, and it should be supported. Thank you.
Thank you for sharing your experience. We can go to our next caller in support.
Caller with the last three digits, 486. Please slowly state and spell your name for the record. You have 2 minutes and may begin.
Hi, my name is Darcy Patterson, Darcy Patterson. Thank you, Madam Chair and committee members. I'm grateful for this opportunity to share my support for AB 345. My daughter, Kirsten Yamaoka, died from a heroin overdose here in Reno, Nevada. She was 21 and it was her birthday. Personally, and as an advocate, there are several reasons I support this bill. With the creation of programs for the prevention of overdoses and disease, those with substance use disorder can come to a non-biased place that will prevent the admission to our hospitals for infection, overdose, and other transmission of disease such as hepatitis C and HIV. The ability to administer opioid antagonists such as Narcan can mean another life saved. If the person who has substance use disorder doesn't remain alive, there is no hope for recovery. This seems elementary, but it is a huge part of how we can guide those to treatment and give education regarding substance use disorder. In Nevada, we have at least one death from overdose every day. Let's create programs in our community that foster harm reduction and reduce the stigma of substance use disorder. Create and provide a safe place to use substances with policies put in place for the safety of those who have substance use disorder and staff of such programs. If this bill had been enacted years prior, there would have been a possibility that my daughter would have been in the presence of someone who legally could have reversed her overdose, therefore saving her life, finding treatment, living recovery, and becoming a contributing member of our community. Please support AB 345. Thank you.
Thank you. We can go to our next caller in support.
Caller with the last three digits, 695. Please slowly state and spell your name for the record. You have 2 minutes and may begin.
Good afternoon, Chair Wen and members of the committee. This is Holly Wellborn, HOLLYWELBORN, Policy Director for the ACLU of Nevada, testifying in support of AB 345. Among the most disastrous costs of the failed war on drugs are its detrimental consequences for public health. Assemblyman Orentlicker is joining the chorus of lawmakers who are moving the state away from the criminalization policies that destroy our communities and people's lives. AB 345 is the right solution to this crisis. Prevention sites offer the promise of reduced overdose fatalities, increase access to health services, and promote overall benefit to public safety. We thank Assemblyman Orentlicker for bringing this legislation and encourage the committee's support. Thank you.
Thank you, Ms. Wellborn. If we can go to our next caller in support.
If you've recently joined the call and would like to testify in support of Assembly Bill 345, please press *9 now to take your place. place in the queue. Chair, we have no more callers in support at this time.
Thank you. Can we go to callers in opposition to this bill?
To testify in opposition of Assembly Bill 345, please press star 9 now to take your place in the queue. Chair, there are no callers in opposition.
And do we have any callers in neutral? Do we have any callers on the line in neutral on this bill? We don't see anyone. So if we can go next to the phone line.
To testify in neutral of Assembly Bill 345, please press star 9 now to take your place in the queue. Caller with the last 3 digits, 200, please slowly state and spell your name for the record. You have 2 minutes and may begin.
Good afternoon, Madam Chair, members of the committee. For the record, Bradley Mayer, partner at Argentum Partners, testifying in neutral today on behalf of the Southern Nevada Health District. Southern Nevada Health District has been at the table as this bill was being crafted, and really for the purposes of providing some information and context. I have some things to share. So first off, the rate of drug overdoses is increasing in Clark County. It's risen from 19.2 per 100,000 people in 2011 to 21.2 per 100,000 people last year. And most of those overdoses are unintentional, and the primary driver can be attributed to the increasing presence of fentanyl in the drug supply. And fentanyl overdoses are concentrated more in the younger population, with an average age of 29 years old versus 49 years old for overdoses not involving fentanyl. In addition to the overdose issue, Nevada received a determination of need from the CDC in 2017 that found the state was at risk for significant increases in hepatitis and HIV infections from intravenous drug use. And so around the world, these overdose prevention sites have evolved as Assemblyman Norlicker mentioned, as a harm reduction strategy, as one of the several responses designed to address the public health concerns associated with illicit drug use. As far as we understand it, no one has been known to have died at an overdose prevention site, and there's been studies in other countries that have found that the presence of these sites has been associated with decreases in infectious diseases over time, such as in Spain, where new HIV infections were cut in half, in Canada, where evidence suggests overdose prevention sites prevent about 80 new HIV cases annually. And Vancouver operates one of these sites, and at that site, between 2003 and 2006, 46% of participants entered the drug treatment program. It is important to acknowledge that there are currently no sanctioned overdose prevention sites operating in the United States. And really, as it pertains to the provisions of this bill that involve or relate to the Southern Nevada Health District, we don't have any issues with how this bill is currently written. And we thank you for your time.
Thank you. Broadcast Services, do we have anyone else in neutral?
Chair, there are no more callers in neutral at this time.
Wonderful. At this time, I will turn this back over to Assemblyman Ornlicker for some brief closing remarks.
Thank you, Chair, and thanks to all my co-presenters and participants in this. As you've heard, we have an opportunity to implement a well-tested, well-vetted intervention that will reduce a lot of harm, save a lot of lives, bring a lot of marginalized people back to our community, to the services they need. There are a lot of proposed interventions that we hope will work, and we don't have much data, but it's hard to imagine having more data than we have to support this. And the fact that the American Medical Association, the American Public Health Association, all these expert organizations have endorsed this should make us confident that this is the right thing to do. So thank you very much for the hearing and for the suggestions. We will continue to work to make sure that we get everything right, and please let me know about other ways we can improve the bill. Thank you.
Thank you, Assemblyman Ornlicker. And with that, I will close the hearing on Assembly Bill 345. And at this time, I will open testimony or open the bill hearing on Assembly Bill 260. This bill provides for confidentiality of contact tracing Assemblyman Levitt, thank you for being patient. Please unmute and begin when you are ready.
Thank you, Madam Chair, members of the committee. For the record, I am Glenn Levitt, representing Assembly District 23 within the southern part of Clark County. I'm here to present Assembly Bill 260 for your consideration. All of you know, since June 2020, contact tracing has been an important strategy for slowing the spread of COVID-19. On June 1st, 2020, Governor Sisolak released the Nevada COVID-19 Disease Outbreak Management Strategy in coordination with the Department of Public Safety, the Nevada National Guard, and the Department of Health and Human Services. This concept of operations identified contact tracing as a key strategy for preventing the further spread of infectious diseases like COVID-19. It is not clear that the Health Insurance Portability and Accountability Act, or HIPAA's privacy rules, apply to groups conducting contact tracing. Former Deputy Director of Health and Information Privacy at the U.S. Department of Health and Human Services Office for Civil Rights, Ilana Peters, said in August that certain entities that are conducting contact tracing are not currently required to maintain confidentiality. There was and still is a recognition by the Nevada Public Health Departments of the need to protect the privacy of those diagnosed with COVID-19, saying that individuals who are at risk not be told the identity of the patient who may be exposed to them. I applaud these efforts to maintain patient privacy in a time when the public health is of utmost importance. However, we can certainly do more to ensure that these attempts be successful, including codifying into law specific provisions that protect patient privacy as it relates to contact tracing. Now I'll go into sections of the bill, if that pleases you, Madam Chair.
That's fine. Please go ahead.
Or would you like me to start my 20 PowerPoints first?
I don't know what you're talking about.
I don't
Unless
either.
you're going to start reading like Susan Furlong, our clerk.
So sections 2 through 4 of the bill define contact tracings and COVID-19. Section 5 of the bill prohibits a government entity or persons from disclosing information obtained through contact tracing. It also prohibits the law enforcement agency from conducting contact tracing and prohibits a court from disclosing information related to contact tracing from a government entity or person. Additionally, no later than 30 days, a person that conducts contact tracing on behalf of the government entity must delete, dispose, or remove of such information. Section 6 of the bill authorizes the government entities that conducts contact tracing may disclose the information if a person gives consent, information is needed to conduct the contact tracing, information is needed to save a person's life, information is needed to protect the public health, the information is needed for an investigation after a person has given consent or information is highly material to an investigation. Additionally, it allows for the representative to consent on behalf of a person for a minor or a person that lacks the capacity to provide informed consent. Lastly, it requires a government entity to keep a written record of that disclosure. Section 7 of the bill requires that government agencies that may disclose information may not include personal identifiable information. Section 8 of the bill requires a state board of health to establish regulations to protect the confidentiality of information obtained by individuals. Section 9 of the bill authorizes the Division of Public Health the Division of Public and Behavioral Health to conduct an investigation and investigate alleged violations. Now, that being said, that was the initial bill. We've had some amendments, some friendly amendments that were conceptually received after talking to the Nevada Department of Health. They had inquired about the 30-day limit for keeping data, and they said that they are required, they are mandated to keep their data for, I believe they said a year. And so in section 5, subsection 5, the period of 30 days will be amended to a year. And in the other friendly amendment, they also raised a concern that that when they're those who are incarcerated, they want to be able to do a further investigation of contact tracing for those who are held in jail or prison. So subsection 5 or section 5, subsection 2 will amend to allow law enforcement to conduct contact tracing when an individual is currently being held in jail or prison. That's my presentation. Sorry it was so brief and short, but that's all I got. And I'm happy to attempt to answer any questions on this complicated issue.
Thank you for that presentation, Assemblyman Levitt. I'm not really sure which Assemblyman Levitt I'm talking to because there's two on my screen. No, you could leave it. I think we need some levity here on a Friday. Do we have any questions from our members? I know that there were some later amendments. Obviously, you know, I appreciate you being able to present this bill with such short notice. But are there any people that have any questions here on the Zoom and in the committee? Oh, look at that. Oh, we do. We've got Vice Chair Peters. Go ahead.
Thank you, Chair, and thank you, Assemblyman Levitt, for bringing this bill. I still, I think, have some confusion around how this differs from what's already occurring for contract tracing. Can you just talk a little bit about the need of the bill in the long term, rather than having it be like policy driven as part of the response?
Well, I don't. It's difficult to answer that question because everything's so unknown with COVID-19, right? We hope that everything will be under control and we won't have to worry about it a week from now, 2 weeks from now, a year from now. We hope, but we don't know. And so I think that putting protections in place now is a step forward in what we're doing, even though we're remedying the situation as it currently exists. The reason for it is because contact tracing does not currently fall under HIPAA. So that's the need for this particular issue. I think that it didn't come about because of the newness of COVID-19.
Vice Chair Peters, do you have some follow-up?
I do. I have one other follow-up question, and it has to do with the limitation of this bill, which is, relatively large to just the COVID-19 situation, and would it make sense to expand it to other like pandemic style scenarios in case we have something like an avian flu outbreak or, Ebola or something like that?
In my opinion, and I'm happy to look into that and expand it beyond just COVID-19 for other diseases that don't currently fall within HIPAA. I think that the main goal of this bill is just so we don't have people that are being arrested or that they're being forced to stay in their house because of information regarding their current COVID-19 status may be released.
Thank you.
Do I have any other questions? I didn't receive any via message, so I'm just looking around here. Seeing none, broadcast services. And Assemblyman Levitt, do you have anyone on the Zoom to testify in support?
I don't believe so. There may be some to testify in neutral or against.
Seeing none, broadcast services, again, I will remind callers, please clearly state and spell your name for the record and limit your testimony to 2 minutes to ensure that we're given a fair and equal opportunity to receive testimony from both support, opposition, and neutral. Broadcast services, is there anyone on the line in support?
Testify in support of Assembly Bill 260. Please press star 9 now to take your place in the queue. Chair, there are no callers in support at this time.
Thank you. Do we have any callers in opposition to Assembly Bill 260?
To testify in opposition of Assembly Bill 260, please press star 9 now to take your place in the queue. Chair, we also have no callers in opposition. Oh, I'm sorry, hold on. Caller with the last 3 digits, 200. Please slowly state and spell your name for the record. You have 2 minutes and may begin.
Good afternoon, Madam Chair, members of the committee. For the record, Bradley Mayer, partner at Argentum Partners, testifying in opposition today on behalf of the Southern Nevada Health District. I would say that we met with Assemblyman Levitt, and we appreciate the intent of what he's trying to bring forth. We actually talked with him yesterday, and we don't want to be in a place where we're opposing this bill, and we hope to work with him to address some of these concerns. But as you'll hear from my colleague in Washoe County, there are some issues here as it pertains to the time limits for holding data in this bill, beginning with Section 5 and Subsection 4, because it jeopardizes current funding streams that have specific requirements that must be met in regards to this data, and of course also disrupts kind of the accepted framework for conducting case investigations and contact tracing. As Assemblyman Levitt mentioned, we also have the issue of the Section 5, Subsection 2, asking that provision be deleted, as currently law enforcement does contact tracing amongst inmates. We do agree on that. We just think we need to work with Assemblyman Levitt a little more on the timelines that exist here, so something's workable for the health districts as it relates to those issues. Of course, I just want to reiterate, we do support the general concept of what is trying to be accomplished here. We just need to do some more work.
Thank you. Do we have any other callers in opposition to Assembly Bill 260?
Yes, Chair. Call-in user, please slowly state and spell your name for the record. You have 2 minutes and may begin.
Hello, Madam Chair, members of the committee. This is Chuck Callaway, Callaway, representing Las Vegas Metropolitan Police Department. Generally, we're in support of the bill. We share the same concern that was just voiced by the previous caller about Section 5.2. We believe that needs to be clarified. Our agency does contact tracing on employees. If we had an officer that, for example, was involved in training or was in a briefing setting and had COVID-19, we have an obligation as an employer to ensure that other workers were not infected, and that involves our risk management section doing contact tracing amongst our employees. And as was stated, there could potentially be issues with CCDC and inmate population with contact tracing. So we would just like the opportunity to have that section clarified. Thank you very much.
Thank you for your testimony in opposition. Do we have any other callers in opposition?
Let me check, Chair. If you've recently joined the call and would like to testify in opposition to Assembly Bill 260, please press star 9 now to take your place in the queue. Caller with the last 3 digits, 672. Please slowly state and spell your name for the record. You have 2 minutes and may begin.
Good afternoon, Chair and Committee. For the record, my name is Joelle Gutman-Dodson with the Washoe County Health District. And I just wanted to thank the bill sponsor for working with us. We're almost there, and I appreciate the amendments that were proposed. However, we still do have one slight problem with Section 5, subsection 5, where it limits the storage of data for 1 year. Unfortunately, I know it sounds interesting that it's different from DHHS, but we have to store data longer for research and measurements that we send to the CDC, among other places, for funding mechanisms. And without changing that time limitation, we could be subject to losing potentially, we have about $25 million in funding streams right now through 2023 for contact investigation. So we're almost there. I appreciate working with the bill sponsor, and I think we can get there on this bill. Thank you for your time.
Thank you. Can we go to our next caller in opposition?
Chair, there are no callers in opposition at this time.
Do we have any callers in neutral at the time?
To testify in neutral to Assembly Bill 260, please press *9 now to take your place in the queue. Chair, there are no callers in neutral at this time.
I think I have one person on the Zoom and to testify in neutral, so go ahead.
Yes. Hi, my name is Lindsay Kinsinger. For the record, I am the manager of the Office of Public Health Investigations and Epidemiology for the state of Nevada. We are testifying in neutral with this bill. I think, like some of the counties expressed, I think we would welcome the opportunity to work with the assembly member to give it a little more clarity. Right now, I can say that we do treat contact tracing and disease investigation data and information for COVID with HIPAA protections. So I will assure you that information is not being given out unless something like a subpoena or law enforcement. But we are here to work with you guys, and we support the idea of the bill and would just look forward to helping you maybe rewrite a few of the things as well as the data policy. So thank you.
Thank you. Do we have any other people on the Zoom in neutral? Seeing none, I will turn this back over to you, Assemblyman Levitt, for any closing statements.
Thank you, Madam Chair. Well, it looks like we're making good progress on this. I apologize that I didn't get the amendments exactly right. I found out about the hearing very recently. So we're still working on the amendments, and I will get those to the committee. I don't think that any of the issues proposed don't seem too difficult to overcome. I will continue to work with the Southern Nevada Health District, Washoe Health District, and all those other stakeholders that voiced their concerns and get the language right so that we can move on and have this go from a great concept to a great bill. And this concludes my presentation on Assembly Bill 260. I believe this is an important piece of legislation to keep individuals' information private. I will continue to work with the stakeholders to ensure we find some common ground, and the working product that we pass out to the committee in the future will be solid. Thank you, Madam Chairs and members of the committee, for your time. Sorry I took so long.
Thank you, Assemblyman Levitt. At this time, I will close the hearing on Assembly Bill 260. At this time, we will move into public comment. As a reminder, if you're providing public comment, please clearly state and spell your name for the record and limit your comment to 2 minutes. Broadcast services, do we have anyone on the line in public comment?
If you would like to participate in public comment today, please press *9 now to take your place in the queue. Chair, the public line is open and working, but we have nobody for public comment at this time.
Well, wonderful. At this time, I will take any comments from members. Do we have any comments before I adjourn today's meeting? Seeing none, I will remind everyone that we probably have a really jam-packed next couple of weeks. As you heard probably on the floor today and with some of our committee introductions, we have quite a few bills that have come in these last couple of weeks. So plan on being here on Monday, Wednesday, and Friday, and possibly we might have another evening meeting if we need to schedule that in order to hear these bills as best we can before first committee passage. So with that, I will adjourn until Monday at 1:30. Have a good weekend, everyone.